Hi students, today we will learn about disorders of skeletal muscles. In that we will read the muscular dystrophy. Coming to muscular dystrophy refers to a group of genetic diseases that is inherited as X-linked, okay, that will cause progressive weakness and degeneration of the skeletal muscles. So what is muscular dystrophy? These are a group of genetic diseases that will cause progressive weakness and degeneration of the skeletal muscles. These disorders, okay, more than 30 are identified. They vary in the age of onset, severity, and the pattern of the affected muscles. All forms of muscular dystrophy grow worse over time as muscles progressively degenerate and weaken. Many people with the muscular dystrophy eventually lose the ability to walk. Some types of muscular dystrophy, they can also affect the heart, lungs, GIT, endocrine glands, spine, eyes, brain or other organs. Some people with muscular dystrophy may develop a swallowing disorder also. It is not a contagious disorder and cannot be caused by injury or any activity. So it is a genetic disease present on the X chromosome. How muscular dystrophy affects the muscles? The muscle fiber membrane contains group of proteins known as dystrophin glycoprotein complex. So you have to know about this in detail. So the muscle fiber membrane has protein called dystrophin glycoprotein complex that prevents the damage when the muscle fibers contract and relax. When this protective membrane is damaged, what happens? Muscle fibers begin to leak the protein creatine kinase CK and take on excess calcium. This damages the muscle fibers and eventually causes them to die, leading to progressive muscle degeneration. Some forms of muscular dystrophy are caused by defects in this dystrophin glycoprotein complex, whereas others are caused by defects in surrounding connective tissue. Still others can be caused by expression of toxic gene products in muscle fibers. Although this muscular dystrophy can affect several body tissues and organs, its hallmark is to damage the integrity of muscle fibers. This damage can lead to muscle degeneration, progressive weakness, fiber death and phagocytosis. So where the muscle fibers are broken down and destroyed by the scavenger cells. And fiber branching and splitting and replacement of this muscle tissue with the fibrous tissue and fat. All these can happen. This muscular dystrophy can be inherited in three ways. That is, autosomal dominant inheritance occurs when a child receives a normal gene from one parent and a defective gene from the other parent. Or it may be due to autosomal recessive inheritance. Means both parents carry and pass the faulty gene. And X-linked or sex-linked recessive inheritance occurs when the female parent carries the affected gene, passes it to the male child. So it can be through autosomal, dominant, recessive or X-linked inheritance. How are the types of muscular dystrophy identified? So the types of muscular dystrophy are grouped by the extent and distribution of the muscle weakness, age of its onset, rate of progression, severity of symptoms and family history. So based on these events, we can classify the muscular dystrophy. First you see this dystrophin glycoprotein complex. This is the complex. This is the sarcolemma. This is the cytoplasm. This is the extracellular matrix. Now, in the cytoplasm, we have actin filaments. Actin filament is connected to sarcolemma with the help of dystrophin protein. And this is connected to dystroglycan complex having alpha and beta forms, and sarcoglycan complex means these alpha, beta, gamma, delta components plus sarcospan protein. All these constitute sarcoglycan complex, and these are the dystrobrevin, and these are the syntrophin proteins. All these will connect the actin filament to the laminin 2. That is, laminin 2 is also called myrosin. It is a component of the extracellular matrix protein. So when a muscle contracts and relaxes, the actin filament is connected to the Z discs. The force of contraction is transmitted along with this actin filament to the extracellular matrix. See this? Dystrophin is thought to physically couple the sarcolemma with the costameric cytoskeleton through lateral association of its N-terminal and rod domains with the cytoplasmic actin filaments, and through direct binding of its cysteine-rich domain to the beta subunit of the dystroglycan complex. So, dystrophin connects the costameric cytoskeleton through that is, the cytoskeleton is having actin filaments. So actin is connected to dystroglycan complex, beta unit of the dystroglycan complex. So this gamma unit of the actin, where the cysteine rich elements are there, that is connected to the beta unit of the dystroglycan complex with the help of dystrophin. Then oligosaccharides present on the alpha dystroglycan are important for its binding to laminin 2 of the extracellular matrix. Now this dystroglycan is connected to the laminin 2, that is myrosin of the ECM, extracellular matrix. Next is sarcoglycan sarcospan complex. Why it is present? It is to strengthen the non-covalent binding of dystrophin and alpha dystroglycan with the beta dystroglycan. So our connection between the dystrophin and dystroglycan is non-covalent. That is strengthened by sarcoglycan and sarcospan complex. Next, coming to the dystrobrevin. Why it is there? It appears to couple the dystrophin with the sarcoglycan sarcospan complex and also link the dystrophin glycoprotein complex with the intermediate filament cytoskeleton. So it is also functioning the same as a sarcoglycan sarcospan complex. These are for strengthen the binding of the dystrophin with the dystroglycan complex. Two syntrophins are attached. They serve as adapter molecules. Means that will localize the signaling molecules near the sarcolemma. So all these are the important components of the dystrophin dystroglycan complex. Dystrophin protein, dystroglycans, sarcoglycan and sarcospan complex, dystrobrevin and syntrophin. All these you have to write and label it. You have to draw the diagram and label these components. See this costameric cytoskeleton of the striated muscles. What is this costameric costamers? Costamers are the protein assemblies that circumferentially align in register with the Z disc of the peripheral myofibrils. So we have myofibrils, especially in the peripheral myofibrils at the Z disc level. Okay, at the Z disc level, this is the Z disc. We have costamers. These are the proteins. Okay, so with the help of this, the fibrils and physically couple the force generating sarcomeres with the sarcolemma in striated muscle cells. So when the muscle contracts, force is generated. So with the help of Z disc and with the help of costamers, the force is coupled and it is transferred to the sarcolemma. So these costamers are attached to the actin filaments. So this is the costameric arrangement of the cytoskeleton of the striated muscles. Now coming to first one, we had to discuss about nine things in the muscular dystrophy. So 9 types are there. First type is the Duchenne muscular dystrophy, DMD. Okay, it is the most common childhood form of the muscular dystrophy because its inheritance is caused by mutation on the X chromosome. This primarily affects the boys, although girls who carry the defective gene may show some symptoms. So this is because of mutation on the X chromosome, mostly present in the boys. DMD results from absence of the muscle protein dystrophin. So here what is not there? Dystrophin protein itself is not present. DMD usually becomes apparent during the toddler years, sometimes soon after an affected child begins to walk. So when the child begins to walk, we can notice the difference. There is a progressive weakness and muscle wasting. Wasting means decrease in the muscle strength and size. So there is a progressive weakness and muscle wasting caused by degenerating muscle fibers. Begins in the upper legs and pelvis before spreading it into upper arms. So in the legs first we can notify this disease. Other symptoms include loss of some reflexes, waddling gait, frequent falls and clumsiness. Especially when running they have frequent falls and difficulty when getting up from a sitting position or when climbing stairs. So when the person is about to get up from the sitting position, he cannot get up. Okay. So next thing is changes in the overall posture and impaired breathing and heart problems like cardiomyopathy can occur. Okay. So here you can see loss of some reflexes, waddling gait, okay, and frequent falls, especially when running, difficulty when getting up from a sitting position, changes to overall posture, impaired breathing, and heart problems like cardiomyopathy. Okay. Next, coming to BMD, that is Becker muscular dystrophy. Becker muscular dystrophy is less severe than but closely related to the Duchenne muscular dystrophy. The disorder usually appears around the age 11 but may occur as late as age 25. And people with Becker muscular dystrophy usually live into middle age. Muscle weakness is typically noticed first in the upper arms and shoulders, upper legs and pelvis. Cognitive and behavioral impairments and heart problems are not as common as in a Duchenne muscular dystrophy, but they may present. Early symptoms of Becker muscular dystrophy are walking on one's toes, frequent falls, and difficulty rising from the floor. We can see one sign, Gover's sign. So, what is this sign? Gover's sign present with any condition that is associated with the weakness of the pelvic girdle muscle or proximal muscles of the lower extremities. It is seen in Becker muscular dystrophy, limb girdle muscular dystrophy, um, uh, spinal muscular atrophy, polymyositis, etc. So, in this, what is there? He cannot get up from the one's position. Okay, so this is big because of weakness of the pelvic girdle muscles or proximal muscles of the lower extremities. Okay, so Gover sign is classically seen in the Duchenne muscular dystrophy. Okay, where it is evident at 4 to 6 years, whereas in BMD, that is Becker muscular dystrophy, it is evident between 10 to 11 years. Okay. So what is called as they will walk their hands up their thighs in order to stand up. So they will walk on themselves to stand up from a sitting position. Now coming to the third one, congenital muscular dystrophy. It refers to a group of muscular dystrophies that are either present at birth or become evident before age of 2 years. So congenital. The degree and progression of muscle weakness and degeneration vary with the type of disorder. The weakness will be first noticed when children do not meet the developmental milestones, which is related to motor function and muscle control. So the children won't attain motor function milestones. Muscle degeneration in congenital muscular dystrophy is restricted primarily to the skeletal muscles. Most people with this they are unable to sit or stand without support, and some may never walk. There are many genetic forms of congenital MD. They will include merosin negative disorders in which the protein merosin, that is laminin 2, is missing. Okay. This is the second one. Okay, second one is myrcene positive disorders, in which myrcene is present but other necessary proteins are missing. So this is the laminin 2 or a myrcene. It is composed of alpha 2, beta 1 and gamma 1 subunits. So it is trilaminar. The recent name is laminin 2,1,1. So this is the structure. So here it will bind to dystroglycan complex. Now, people with congenital muscular dystrophy may develop contractures, that is shortening of the muscles or tendons around the joints, and scoliosis, that is curved spine, breathing and swallowing difficulties and foot problems. Now coming to the fourth one, that is distal muscular dystrophy. So it is affecting the distal muscles. Distal muscular dystrophy is also known as distal myopathy. Describes a group of muscle diseases that are primarily affect the distal muscles in the forearms, hands, lower legs and feet. These are typically less severe but progress more slowly and involve fewer muscles when compared to the other forms of muscular dystrophy, although they can spread to other muscles. Distal muscular dystrophy can affect the heart and respiratory muscles also, and they eventually need a ventilator. They may not be able to perform fine hand movement and may have difficulty in extending the fingers. Walking and climbing stairs may become difficult, and some people may be unable to stand on their heels. Now coming to the fifth one, Emery-Dreifuss muscular dystrophy. So onset is at the age of 10 years, but symptoms may appear at 20 years, mid-20s. This disease causes slow yet progressive wasting of the upper arm and lower arm, leg muscles and symmetric weakness. Contractures appear in the spine, ankles, knees, elbows and back of the neck, usually precede significant muscle weakness. So first contractures will be appearing, then muscle weakness will be appearing. Contractures may cause elbows to become them in a locked and flexed position. The entire spine may become rigid as the disease progresses. And the other symptoms will be shoulder deterioration, walking on one's toes, and mild facial weakness. Next, coming to the facioscapulohumeral muscular dystrophy, FSHD. It initially affects the face, shoulders, and upper arms with progressive weakness. It is also known as Landucci-Dejerine disease. This is a relatively common form of MD and is characterized as an autosomal dominant disorder. Most people with this disorder have a normal lifespan, but some become severely disabled. These are the sarcoglycans, alpha, beta, gamma, delta, and this is the sarcospan. So the whole thing is called sarcoglycan complex. So the sarcoglycan complex is composed of alpha, beta, gamma, delta sarcoglycan isoforms and a sarcospan. Single transmembrane glycoproteins. They are single transmembrane glycoproteins with the N terminus is oriented extracellularly for alpha and intracellularly for beta, gamma and delta forms. Sarcospan is consisting of four transmembrane spanning segments which are homologous to the tetraspanin family. So this sarcospan is belong to the tetraspanin family of the proteins. It is for the strengthening of the interaction between the beta dystroglycan with the alpha dystroglycan and with the dystrophin. Okay, so it is for the strengthening. Now coming to the myotonic dystrophy. Myotonic dystrophy DM1 is also known as Stainer's disease or dystrophia myotonica is another form of muscular dystrophy. Myotonia or the inability to relax the muscles, okay, following a sudden contraction is found only in this form of muscular dystrophy. So what is this myotonia? There is inability to relax the muscles after a sudden contraction. People with this disease, myotonic dystrophy, can live a long life with a variable but slowly progressive disability. Typical disease onset is between 20 to 30 years of age, but childhood onset and congenital onset are also well documented. Muscles in the face and front of the neck are usually first to show the weakness and may produce a hollow temples, drooping facial skin, and a thin neck. Wasting and weakness noticeably affect the forearm muscles. DM1 affects the central nervous system also and other body systems also, including heart, adrenal glands, thyroid, eyes, and GIT. Second form, known as DM2, that is myotonic dystrophy type 2, is similar to the classic form but usually affects the proximal muscles more significantly. Childhood onset form of myotonic muscular dystrophy may become apparent between the ages of 5 to 10 years. The symptoms will include general muscle weakness, particularly affecting the face and muscles farthest away from the center of the body, and lack of muscle tone, and there is a cognitive impairment. Now coming to the next thing, oculopharyngeal muscular dystrophy. The people first report drooping eyelids, followed by weakness in the muscles of the face, tongue, and throat that can cause problems with the swallowing. Sometimes there will be changes in the person's voice also. The people with the oculopharyngeal muscular dystrophy may also have double vision, problems with looking up, that is upper gaze problems, retinal degeneration that affects the night vision and peripheral vision. It can lead to retinitis pigmentosa and heart problems, and muscle weakness and wasting in the neck and shoulders is common. Limb muscles are also may be affected. People with this disease may find it difficult to walk, climb stairs, kneel, or bend. People who are severely affected by this disease will eventually lose the ability to walk also. How is muscular dystrophy diagnosed and treated? So, we have completed the 9 forms. So, we can see this the mode of inheritance: autosomal dominant, autosomal recessive, and X-linked. All these three are present in Emery-Dreifuss muscular dystrophy. Autosomal dominant and autosomal recessive are present in limb-girdle, okay, limb-girdle muscular dystrophy. Autosomal dominant exclusively for facioscapulohumeral, okay, myotonic, oculopharyngeal, and late onset distal, that is older than 40 years of age. So they will show the autosomal dominant disorder. And autosomal recessive seen in congenital muscular dystrophy and early onset distal muscular dystrophy, that is younger than the 40 years of age. And X-linked seen in Duchenne muscular dystrophy and Becker muscular dystrophy. So again I am repeating, X-linked seen in Becker and Duchenne. So first we have discussed Duchenne and then we have discussed Becker. So both these two are X-linked. Now coming to autosomal dominant. They are facioscapulohumeral, late onset distal muscular dystrophy, myotonic, okay, and oculopharyngeal. Next coming to autosomal recessive, that is congenital muscular dystrophy and early onset distal muscular dystrophy, that is younger than the 40 years of age. Then both forms, autosomal dominant and autosomal recessive, are present in limb-girdle muscular dystrophy. And three things, autosomal dominant, recessive, and X-linked, they are present in Emery-Dreifuss muscular dystrophy. Now, next coming to how is muscular dystrophy diagnosed and treated. So, we can diagnose the thing by blood and urine tests. And exercise tests also we can do. So, these exercise tests, they will detect the elevated rates of certain chemicals released during the exercise or after the exercise. And we can do genetic testing and genetic counseling also. This genetic analysis is the standard method to diagnose people who are expected to have muscular dystrophy and for characterizing the type of the muscular dystrophy. Okay. Amniocentesis during pregnancy to test a sample of amniotic fluid in the womb. So what is amniocentesis? We will take amniotic fluid from the womb and we will test genetically. So that is also helpful. And CVS, that is chorionic villus sampling. It can also be tested. To test the very small sample of placenta is taken during the early pregnancy. So placenta, a part is taken in that the chorionic villi are examined. Diagnostic imaging including MRI technique, that is magnetic resonance imaging, and phosphorus magnetic resonance spectroscopy, and sonography to examine the muscle quantity, atrophy, or other abnormalities. And muscle biopsies can also be done to monitor the course of the disease and treatment effectiveness. And immunofluorescence test is for detecting specific proteins within the muscle fibers. Electron microscopy will identify the changes in the subcellular components of the muscle fibers. And it can also identify changes in the changes in the cell death and mutations in the muscle cell mitochondria and an increase in the connective tissue component. So we can do blood test, urine test, exercise test, genetic analysis, and in the womb we can do amniocentesis, chorionic villus sampling, and after that we can do MRI, muscle biopsy, immunofluorescence test, electron microscopy also. And neurophysiology studies can also be done to identify physical or chemical changes in the nervous system. And nerve conduction velocity NCV can also be done to measure the speed and strength with which an electrical signal travels along a nerve. This can help determine whether the nerve damage is present or not. And repetitive stimulation can be done to assess the function of the NMJ neuromuscular junction by electrically stimulating a motor nerve several times in a row. And EMG can also be done, that is electromyography. It will record the muscle fiber and motor unit activity. Results may reveal electrical activity characteristic of the muscular dystrophy or other neuromuscular disorders. So with the help of EMG, we can classify whether the muscle is affected or actually the nerve is affected. So all these tests we can do for the muscular dystrophy patient. Now how to treat the muscular dystrophy? Drug therapy may be prescribed to delay muscle degeneration in muscular dystrophies. So there are several drugs which are approved by FDA, that is Food and Drug Administration in the US, to treat individuals with a DMD, that is Duchenne muscular dystrophy. They can be given orally or by injection. Steroids such as prednisone and deflazacort and immunosuppressive drugs can also be given for helping the person to slow the rate of muscle deterioration and damage to the muscle cells. But these will carry the side effects that can be especially troubling the children because they will be the long users. There are also drugs available to treat the symptoms of the muscular dystrophy, including myotonia, that is muscle spasms and weakness. Breathing symptoms may be treated with the antibiotics. Physical therapy can help improve movement and keep a person's muscles as flexible and strong as possible. Passive stretching can also support joint flexibility and prevent contractures. And occupational therapy can help the people to perform everyday tasks at home and at work. Speech therapy can help the people the vacant facial and throat muscles they will to communicate. Regular moderate exercise or physical activity can help people with the muscular dystrophy to maintain muscle function and mobility. So we can give drugs like steroids and antibiotics, and physical therapy, speech therapy, occupational therapy can be given. And deep breathing exercises and coughing exercises can also help in the muscular dystrophy patient who are having breathing problems. And support aids such as wheelchairs, splints, braces, spinal supports, posture correction devices can also be given to counter the muscle weakness and help the people with the muscular dystrophy to maintain mobility. No dietary supplements, specific foods or specific diets have been shown to slow the progression of muscular dystrophy. These people with MD should eat well as a way to support their overall health. People with MD who have trouble swallowing may need to use special techniques for feeding. Corrective surgery can be done for complications which are occurring from MD, including tendon release surgery or muscle release surgery for contractures and pacemakers for heart problems, and surgery to reduce scoliosis related to pain or postural imbalance, and cataract surgery for eye problems. Assisted ventilation is often needed to treat respiratory muscle weakness that accompanies many forms of muscular dystrophy, especially in the later stages of the disease. So we can start deep breathing exercise, coughing exercise, supporting aids. Okay. and corrective surgeries and assisted ventilation may be needed. Gene replacement therapy. So this is the advanced one. Clinical trials are going on for gene replacement therapy for Duchenne muscular dystrophy. Okay, that is delivered through the bloodstream throughout the body have been conducted for several groups. The first gene therapy was approved by FDA in 2023. Additional trials are going on to further understand the efficacy and durability of such treatments. Several other therapies for DMD have been approved in the past few years, including gene fragments called antisense oligonucleotides that allow for muscle cells to produce shortened but functional forms of dystrophin. So we will replace that particular gene fragment with the antisense oligonucleotide. So this will produce shortened form of dystrophin, but it's a functional forms of dystrophin. And the next thing is atrophin. Okay, utrophin is a protein that is closely related to dystrophin and it is not affected in the gene mutations that cause the Duchenne muscular dystrophy. Increased expression of atrophin may prove a useful approach in treating DMD. Okay, NIH supports both gene therapy and small molecule drug development programs to increase the muscle production of the atrophin. So it is also can be tried. Additionally, modified genes, that is, genes with activities that act to reduce the severity of the muscular dystrophy, have been discovered by NIH funded teams and represent new therapeutic targets to potentially reduce the severity of several types of muscular dystrophy. Most individuals with Duchenne have mutations in the dystrophin gene that cause it to function improperly and stop producing the dystrophin protein. We will manipulate the protein synthesis process, that is production of a gene that either reads through or skips the genetic mutation, can result in at least partial functional dystrophin protein production. Clinical trials are underway for myotonic, facioscapulohumeral and other forms of muscular dystrophy. So this modified genes can also be tried. So these modified genes, what they will do? They will manipulate the protein synthesis process. Okay. So all these are under study at present. Mainly they are targeting Duchenne muscular dystrophy. And clinical trials are also going on for other forms of muscular dystrophy. So we have seen the muscular dystrophy, what is that? And the types of muscular dystrophy and its inheritance. That is X-linked inheritance and autosomal dominant and autosomal recessive inheritance. So chromosome number 4 is involved in the autosomal form of inheritance. Okay. So we are able to see all these things in a single look. You see this Duchenne muscular dystrophy. The symptoms are weakening of the muscles and can also cause breathing issues and heart issues. Affects only males. So this is X-linked. Affects arms, legs and spine. There is a fast progression. Usually live until teenage years or early 20s only. Okay. So this is the prognosis. Now coming to Becker. That is, it is also showing weakening of the muscles. Affects only males. This is the X-linked form. And age of onset between 2 to 16 years up to 25 years also. Affects arms, legs and spine, can cause heart problems. Can live up to adulthood. Next coming to congenital thing. It is causing weakening muscles and joints and stiffness. Okay. And shortening of the muscles. Okay. So weaken the muscles, stiffness and shortening of the muscles. Presents at birth. Congenital present at birth. So congenital is because of autosomal recessive disorder. And it primarily affects the many voluntary muscles. And progression varies, can have shorter lifespan. So it will shorten the lifespan. Next coming to Emery Dreyfus. It can come as it causes muscle weakening in upper upper arms and lower legs. So it can come as autosomal dominant, recessive and X-linked. It can affect any time between childhood and teenage years. The upper arms, lower leg muscles, chest and shoulders are affected. There is a slow progression of the disease. Next, coming to facioscapulohumeral. Difficulty in walking and chewing and speaking present in this disease, and usually presents between teenage and early adulthood, and it will affect the face, shoulder and upper arms. It is also showing slow prognosis. So this is an autosomal dominant disease. It is also called Landauget-Dejerini disorder. Now coming to limb girdle. Limb girdle is because of autosomal dominant or autosomal recessive inheritance. In this, the symptoms are weakening in the hips, shoulders and arms and legs. Teens are affected. It will affect the hips, shoulders, legs and arms muscles. There is a medium progression. Typically live up to middle adulthood. Now coming to myotonic type of dystrophy. That is also autosomal dominant. There is a stiffening and spasms of the muscle. It will affect any time from a childhood to adulthood. Overall muscle weakening is there and can also affect central nervous system. And there is a slow progression and there is a decreased life expectancy because of this disease. Next, coming to oculopharyngeal. It is also autosomal dominant inheritance. There is a weakening in the eye and facial muscles. Appears between the 40 to 60 years old. So the muscles affected are face muscles and possibly pelvic and shoulder muscles. There is a slow progression of the disease. Now coming to the distal type. So distal type, early onset, that is younger than 40 years of age. It is because of autosomal recessive disorder. Late onset, that is older than 40 years. If it is coming, it is because of autosomal dominant condition. It causes weakening in the distal muscles, appears during adulthood, affects the distal muscles such as hands, feet and lower legs. There is a slow progression of the disease and less severe forms than the other forms. So all these 1, 2, 3, 4, 5, 6, 7, 8, 9, 9 forms are there in muscular dystrophy. Okay. Then the next video is about malignant hyperthermia and myasthenia gravis.